Do you work with patients who have chronic pain? Do you struggle to help them because of the complexity of persistent pain, the regular flare-ups that they experience, and the lack of treatment options available? This can be an ongoing struggle, one that I've definitely felt before, with patients continually presenting in your clinic, with you desperately questioning what to do next. Well, in this video, I'm going to share 5 absolutely critical lessons that I've learned working as an advanced pain practitioner over the past few years, so you can apply these lessons to your own practice and begin helping your patients more effectively. Hey friends, Mahin here. So currently, 1/3 of the people living in the UK have chronic pain, and chronic pain is the leading cause of disability worldwide. Despite this though, persistent pain is still really poorly managed. So here are 5 important lessons that I've learned whilst working in pain management and things that you should know too. Communication is more important than the treatment you offer. Patients need to feel listened to and validated, and for a lot of people, you actually might be the first person who gets the opportunity to do this. The most important thing in a first appointment, after screening for all the nasty and serious stuff, is ensuring that the patient has a chance to tell you about their journey and for you to identify their expectations around treatment and prognosis. It's really important that we begin to build trust in this appointment before we even move on to things like education, challenging beliefs and expectations, or even management planning. As with anything, it's always interaction before intervention. We're trying to treat the wrong type of pain. Diagnostics and investigations for pain mainly focus on identifying nociceptive and neuropathic pain, whether this is through an MRI, an X-ray, or a nerve conduction study. There's no such thing as a pain scan or a pain test, and these investigations mentioned only focus on the biomedical or structural influences of pain, which we know only make up a very, very small part of the overall pain picture. Conventional treatments aimed at treating nociceptive and neuropathic pain, such as medications, injections, and surgery, do not work for nociplastic pain. And it's nociplastic pain that most chronic pain will present as. People don't want pain medication, they just haven't been told about the other options. In my experience as a prescriber, when people come to me to discuss their pain medication, most come because they think medication is the only option, or they've been told to consider medication by a health professional or their GP. After discussing the evidence and what we know about medication for persistent pain, most people actually share that they don't want to take any more medication or any medication at all for their pain because of their previous experiences of it not working or them getting a lot of side effects whilst being on these medications. All medications come with side effects, and a lot of the time for pain, especially chronic pain, the side effects of taking these medications will begin to outweigh the benefits the longer someone's been taking a medication for. As a general rule, the longer we take medication for, the less effective it becomes over time. And a lot of people see this in their own experiences, especially when we start to talk about opioids and how people over time, they actually increase their doses of opioids because the lower doses are not having an effect anymore. So then in increasing doses have the same effect, which is known as tolerance. When we start to point that out to patients, a lot of people already recognize that. But a lot of people attend the appointments for medication because they aren't aware of the other options, so they feel that medication is the only option for pain, when, again, we know this makes up only a very small part of what can be done to help with pain. We avoid telling people their pain may not go away. So many times in clinic, I hear clinicians beating around the bush and avoiding the difficult conversation around the fact that someone's pain may not go away. When I've brought this up in clinic with my patients, it's the single moment that I can point out from all of the moments combined in the consultations that I have, where people are most likely to begin crying or really have an emotional response. It's a really difficult thing to hear when someone's telling you that the pain might not go away. But it's so important that we do that, because although it's an upsetting moment, a lot of people come back to me then the next appointment and say, actually, this is really what I needed to hear, because now I know I can move forwards knowing that the pain is something that I may not be able to control. What this allows is for a shift to happen. So rather than patients then focusing all of their time, energy, and resources into trying to control the pain, they have the same time, energy, and resources available now to spend on the things that they want to do and the things that are important to them. So it's that shift between how do I get rid of or reduce this pain to, what matters to me in the long term, even with this pain still here. We set the wrong expectations around exercise. We often promote exercise as a way of reducing pain, when actually there's no real strong evidence that exercise reduces pain in the long term for chronic pain. We also know that exercise-induced hypoalgesia is reduced in patients with chronic pain following exercise compared to people who don't have chronic pain. And actually, a lot of the time, exercises can increase pain. So rather than promoting exercise for pain relief, what we should maybe do instead is promote exercise for improvements in physical activity for health reasons, for an improvement in function related to people's important activities, and a reduction in the sensitivity to certain avoided activities. We have much more influence over physical activity levels, improving function, and reducing sensitivities to certain movements than we do on pain itself. So let's promote these things rather than general pain relief, as we don't have much influence over that. I often tell my patients that in the worst case scenario, when we start exercises, you're very likely to have an improvement in your function and your physical activity levels, but your pain may stay the same. The best case scenario is that activity levels increase, function improves, and your pain improves slightly as well. The truth is, we don't really know how someone's going to respond on a pain relief level until we've started the exercise and we've been doing them consistently. But it's important to promote moderate intensity exercise for people with chronic pain, as this type of exercise often leads to less pain following exercise than the high intensity exercises. If you like this video, then you'll find this playlist that I made specifically for clinicians like yourself also helpful. There are videos on the top 5 challenges faced when working with people with chronic pain, why tests for pain return normal, and how to help someone with pain in less than 10 minutes. So this playlist will hopefully build on the stuff that you've already learned in this video. Thanks for watching, have a lovely day, and I'll see you on the next video.